Welcome back, everybody. I'm Alain Combe from Paris, France. I've the honor and privilege to moderate this session about cardiogenic shock. We have many talks tonight, probably not a lot of time for questions. So I will ask all the speakers to, if possible, remain in the 10 minutes time which is allocated. So the first speaker is Dan BREAKOUT from New York City on the pathophysiology of cardiogenic shock.
Thanks, and it's great to be here. And I was asked to give this talk with the title Pathophysiology of Cardiogenic Shock from Bench to Simulation Modeling. So these are some disclosures. And I think in terms of pathophysiology of shock, this is probably one of the most famous images that you can see from Judy Hockman. And if you go through the sequence here, there's a primary insult to the myocardium. There's an effect on RV and LV function. This results in reduced blood pressure, cardiac output, and variable changes in CVP and wedge pressure and acidemia. But then there are these secondary effects of baroreceptor activation, which include increases in heart rate, increases in SVR, venoconstriction, which results in increased stress blood volume. But more recently than the earliest initial presentation of this image, then it was recognized that in the chronic state, an inflammatory state sets in and multi-organ failure can result. So this is how many people are taught about the pathophysiology of cardiogenic shock, and that's all well and good. However, from a hemodynamic perspective, if we really want to dive deep, from my perspective, if you need to really dive deep into what's happening at the ventricular level, and when we do this, we think about pressure volume loops. And I won't go through the details because we have no time, but this is a normal pressure volume loop. It talks about the 4 phases of the cardiac cycle, the end-systolic and end-diastolic pressure volume relationships. If we get into, also we can use pressure volume loops to understand ventricular vascular coupling. We understand what happens when you change preload, when you change afterload resistance, what happens when contractility changes, and what happens when the diastolic properties change. And all of these things are really critical for understanding integrated physiology of cardiogenic shock, but also even maybe more importantly about what happens when you start using devices. In addition to hemodynamics, we can really understand a lot about energetics. And here on the pressure volume diagram, we can divide the total work that the heart does into the external stroke work and the potential energy. And then there is a linear relationship between the sum of those two, which is the pressure volume area, and myocardial oxygen consumption. And we can even go further and divide the total oxygen consumption into those things related to contractility, which relate to calcium cycling, and then also to the actual work, which is related to the cross-bridge cycling. So this is also relevant for understanding hemodynamics of mechanical support in shock, but also, maybe even more importantly, the impact of drugs on the mechanoenergetics of patients that are getting in cardiogenic shock. So the cardiovascular system is basically a couple of pumps and a lot of tubes that are connected with each other. And that lends itself very readily to simulation, mathematical simulation. And on the left, we see here a depiction, animation of the cardiovascular system. And on the right side, we see an electrical analog. And you can see the right atrium, right ventricle, left atrium, left ventricle. These are what are referred to as time-varying elastances, that there's energy that is used to change the capacitance or the compliance throughout the cardiac cycle. And then the pulmonary vasculature is a series of resistors and compliances, and so too is the systemic vascular system. So these kinds of models can be very, very easily modeled, represented by a series of differential equations that can be solved in real time to generate in real-time simulations of the cardiovascular system. So here's how we would simulate the cardiogenic shock of isolated left ventricular failure. You see on the left ventricular side, the end-systolic pressure volume, whoops, sorry. Let me go back. There we go. The end-systolic pressure volume relationship of the left ventricle is going to decline, indicating the abrupt reduction in ventricular contractility. You see that the blood pressure goes down, the cardiac output goes down. That leads to the baroreceptor activation with increased heart rate. The loops will go around faster. Then there's increases in SVR, stress blood volume, and pulmonary wedge pressure, which is indicated also by the end diastolic pressure in the ventricle is going up. Now, in terms of the CVP, there are variable changes, as you know, but with isolated left heart failure, CVP would tend to be either the same or may even go down. This is now the pathophysiology of isolated right heart failure, where you have a primary reduction in RV contractility, and that results in underfilling of the LV, so the end diastolic pressure and wedge pressure go down. That is what results in the reduction in the cardiac output and blood pressure, but you have the same activation of the baroreceptors with heart rate, SVR, and stress blood volume, but in this case, the CVP goes up and the wedge pressure may go down. So that's isolated left, isolated right, but in reality, there's usually a mix of biventricular involvement. And here you see that there's a reduction in both the RV and the LV and systolic pressure volume relationships. And now everything is kind of the same, except there's more variable changes in CVP, and wedge becomes much more difficult. So in the end, the pathophysiology of cardiogenic shock depends on the baroreceptors. It depends on the relative contributions of RV and LV decline in contractilities. Now, these simulations can be extended to include ventricular assist devices, including ECMO. So we can take blood, we can introduce mechanical flow pumps to take blood from either the RA and the RV and put that to the pulmonary circuit, or from the LA or the LV and pump it to the systemic circulation. And we can make connections from any chamber we want to the other, as would occur during ECMO. So here we see some simulations of, this is now a patient who's already in cardiogenic shock, and now we can introduce various configurations of ECMO. This is called the sport model, going from this returning blood to the subclavian artery. There we go there through peripheral ECMO. Here we're going from the PA to the LV. Now we have to the LA. Now we have VV ECMO, and we can see both what's happening in terms of effects on the hemodynamics in both the RV and the LV, pressures in the various chambers, and also what you see here up here is we can also simulate what's going on with the blood gases. And getting a little bit more deep into the blood gases, what you can see here is we've got now all the different chambers from the pulmonary vein, LA, LV, cardiac, central aorta, arterial system, venous system, RA, RV, pulmonary artery, and then the lungs. We can introduce, we have the lungs that are exchanging CO2, that are putting oxygen in and taking CO2 out. We've got the body, which is taking oxygen out and putting CO2 in. And we can then also put ECMO here, where we've got a certain amount of oxygen that's coming in and CO2 that's going out. We can simulate all of these kinetics, not only now of hemodynamics, but also metabolics. So just to get a little bit deeper, this is a simulation of ECMO, where we see that the increase in the afterload pressure is actually, in this particular case, causing an increase in afterload on the LV, and which is simultaneously then resulting in an overload of the LV, because the end diastolic pressure and therefore the wedge pressure are increasing. This would be a case of a patient who needs to have LV unloading. From the energetic point of view, in this kind of a setting, you can see here that this is now that MVO2-PVA relationship, that in this kind of setting, this effect of ECMO would result in an increase in the myocardial oxygen consumption. But as we know, not every patient who gets put on ECMO, actually the LV is loaded. And we can start to use simulations to understand why that is. And here's one explanation, just one of many explanations why not every patient needs unloading, is here, once we initiate ECMO, there's increased perfusion of the coronary arteries with blood and also oxygenated blood, and the contractility is increasing. So that is one way that the heart can avoid getting overloaded during ECMO. There are other ways, because we know now, we're starting to get more data from animals and humans, that we know that Things like putting patient on ECMO changes the SVR, changes the stress blood volume, et cetera. So it's not so simple as just saying the only effect of ECMO is to take blood from one place to another. There are many things that happen when you place a patient on this extracorporeal circuit. Now here we have, on the other hand, this is now an Impella, a transvalvular pump, where you see here, in contrast to ECMO, you would, no matter what, you would always have unloading of the left ventricle. You'd have a classic change in the configuration of the loop from a rectangle to a triangle because of the continuous flow. You may have aortic ventricular pressure uncoupling, and this is in contrast to ECMO, where a closed aortic valve is a very big problem. A closed aortic valve with Impella is is telling you that the device is doing what you want it to do. So these kinds of simulations are very helpful for teaching people when they're starting to work in the intensive care unit, taking care of these patients. What is the difference in the care of a patient on ECMO versus a patient who is on a ventricular assist device? And also energetically, we can understand that unloading the ventricle also results in a reduction in the myocardial oxygen consumption. We've also used our simulations to understand and compare the different strategies for unloading the LV in the case of unloading. So you see here there are eight different strategies that we considered. You see that they can all have different effects on the ventricle, and I think it is relevant to understand the relative advantages and also the limitations of each of these, and in which clinical setting one might be interested in using one or the other. So I've just shown you, I think, that we can simulate the cardiovascular system in cardiogenic shock. We can simulate the effects of various devices, but the question is, so what? Who cares? Some people will look at this and say, no clue of what's going on. Other people will get really excited and energized. So there's a big variety of reaction to this kind of stuff. But why do we do it? And we've been at this these simulations started when I was a medical student in 1984, was the first version of these programs. So why continue? Well, first of all, in the current era in medical schools, and maybe, I don't know, in nursing schools and PA schools, but there's very little teaching about hemodynamics. So people lack the fundamental understanding of what are the basics of hemodynamics. So these simulations provide theoretical foundation for understanding the hemodynamics and energetics of pathophysiological conditions, MCS, and blood gases for healthcare professionals at all levels of training. The platform is mainly a platform for education of basic and advanced hemodynamic principles. These simulations are dynamic, they're real-time, they're interactive. You can sit in front of the computer and change whatever you want. There are multiple, easy-to-understand output graphics, and the simulations are very customizable. These allow for preliminary testing and framing of hypotheses related to hemodynamics of shock and MCS. And for example, I've shown you factors that underlie whether or not a patient is more or less likely to require LV unloading during ECMO, and also comparative hemodynamic benefits of limitations of 9 different strategies of unloading the ventricle during ECMO. So I think there are many reasons to embrace simulation. I think, the reception of these are variable depending on where you come from and your level of interest. But we've been working on these simulations for quite a long time, and they continue to evolve. So I hope I've been able to convince you that simulations are valuable, and I think I'll stop there. So thank you very much.
Thank you very much. We move on to the next talk. It's going to be delivered by my good friend John Fraser, who is working in Brisbane, Australia. How ECMO can win the battle.
Thanks, Alan, and the Society for inviting us. It's lovely not to be presenting from my living room. It's a long way here, so I've got, I think, 11 minutes, so thank you. Thanks also to Dr. Berkoff, who's covered some of the ground. I think we all know versions of this diagram, where we've come from in cardiogenic shock, and we're going to hear from Suzanne where we're going to go to. But realistically, whilst we've moved substantially from when it was first diagnosed and first discussed to angiography, shock trials, we haven't really done too much success. It's a little bit sad to say that, but as we sit here as zealots in the field, we need to accept the fact that we really haven't come perhaps as far as we'd like to have done. As we look through the last 2 decades in cardiogenic shock, the mortality has really not improved substantially. Our use of mechanical support has. So what's going wrong? If we're using more mechanical support and we're not getting better outcomes, what is going wrong? There's a big surge in mechanical support, and a lot of that was due to VV ECMO. Perhaps these are some of the reasons that are put forward. We're picking the wrong patient device selection. We're timing it wrongly, and I think timing is a key part, but why? Inability to decompress the left ventricle, but we would also put forward the inability to resuscitate the microcirculation. This is what we're really going to talk about. Again, Dr. Burkoff's quite nicely set up. This is the discussion that we're told about. This is the old classic paradigm of cardiogenic shock, reduced contractility to reduced organ perfusion. But we understand more and more that it is not just a pump function, it is very much an inflammatory function as well, that in shock we see systemic inflammation, there's a cytokine storm, nitric oxide, systemic vascular resistance, but not always the SVR is increased, and we understand that inflammation in sepsis, but also cardiogenic shock, leads to organ dysfunction, morbidity, mortality, and then death. We became interested in this area looking firstly at VV ECMO and the inflammatory response that comes not just with the pneumonia that necessitates the VV ECMO, but the actual VV ECMO-induced inflammatory state itself. So from inflammation to multi-organ failure, we understand that the inflammatory cascade kicks off with the exogenous pathogen. There's inflammation, but we can have sterile and non-sterile inflammation. And all of these changes result in changes in nitric oxide with reduced perfusion pressure, sometimes capillary thrombosis, changes in the endogenous anticoagulants like protein C and its inactive zymogen. And when this happens and the microcirculation starts to shut down, then we see microcirculatory collapse. So we see perhaps a normal blood pressure in the macrocirculation, but we're not assessing the microcirculation, and it's at this level that we start to see multi-organ failure. The pressure can be the same, but we understand from the circulation and the oxygen delivery to the mitochondria it's not. So a number of years ago, we worked with Mervyn Singer, a good friend in London, looking at what the microcirculation was, why it was dysfunctional, and what happened. We've got to remember that the microcirculation is actually the largest organ in our body. We talk about the arterioles, venas, capillaries, and these are 3 of the components that affect the ability of the microcirculation to deliver oxygen to the tissue. And that's where it happens. It's not at the heart, it's not at the lungs, it's at the microcirculatory level. And there's a whole pile of regulators, myogenic, metabolic, and neurohumoral. And these things are key affected by ECMO. Because in health, the macrocirculation and the microcirculation correlate and couple very, very well. But in illness, the macrocirculation and microcirculation are totally uncoupled. And it's at this point that we see shock. One of the areas we look at, and it's really fiddly, and it's not for all people, and you can only look at certain organ beds, but is looking at microcirculation. And we'll just see if this one, if we can just, Mr. Computerman, if you can just click on that video, please, for me. So thank you. So this is us looking at one of our sheep in our animal lab, looking at the microcirculation. And it's lovely and it's pretty and it looks great in PowerPoint. But what we can actually look at is we can track the red cell velocity and we can track the capillaries opening or closing, either in response to sepsis in our lab or in situations on ECMO as well. Cam Ince's group looked at the microcirculation assessments on ECMO and showed very clearly that perfused vascular density, PVD, it looks at how many capillaries are actually open or shut, that the PVD has a superior sensitivity and specificity for prediction of mortality when compared to the macrovascular, the blood pressures, the urine outputs, the arterial gases. From Paris, from Alain and Mathieu's group, Dr. Chomelu, I hope I've pronounced it correctly, showed the same thing. People that have microcirculation resuscitated do better. Now, I think most of us understand that unless you resuscitate the microcirculation early, it becomes non-resuscitatable. That's probably part of the reason why we have to institute ECMO earlier in the cardiogenic shock field, because once the microcirculation has shut down, has thrombosed, the endothelium's damaged, then it's very, very difficult to resuscitate it. So these are the findings. Microcirculation improves, and it directly relates to mortality, and it has to be done really within the first 48 hours. We always talk about going in early. Why? It's because of the microcirculation. So there's many, many different methods people have talked about: inotropes, dobutamine, dopexamine, levosimendan, many, many. These are pharmacological agents. But I would put it to you that the mechanical agent we're using can be used much more effectively. And pulse. We understand that at the capillary, there is lack of pulsatility, but the vascular system is an endocrine organ, and the pulse creates endocrine effects. There's hormones released, the glycocalyx becomes much more functional and releases a whole pile of heparins and other molecules. So we understand that the pulse improves microcirculation, changes the change in the shear stress, induces enos. We understand that the pulse increases 15% the energy equivalent potential, which is important to keep the capillary open to give you that better vascular density that Alain's group showed is important. And we also understand that pulsatile circulation reduces inflammation. And if you go back to our paradigm of what cardiogenic shock is in the inflammatory cascade, these are all key things that when we put people on continuous VA ECMO, they lack. So we understand the microcirculation is important, it's the largest organ, and it seems to be one of the biggest correlators. So the question is, how do we go from a non-pulsatile ECMO to a pulsatile ECMO? And this is some work that we're continuing in the CCRG in Brisbane, and we have some funding from Xenios, but they're not involved in this study. So with a very talented young fellow from Estonia, Silver Heinzer, and also with thanks to Roberto Larusso, who's helped with this model, and Jan Balacevic as well, we've created a lovely model, a reproducible model of cardiogenic shock. We tried many things. We initially started with pacing, carbon monoxide poisoning, you name it. There's a lot of things out there, but they're not particularly relevant. If you tie off coronary arteries, I proved this when I was a senior registrar, your sheep die. You can write that one down. So the ethics committee don't like you, and as a Scottish person, it costs lots and lots of money, and I don't like that either. So we created this model, as I say, with Roberto and Jan, and in fact, one of Alain's colleagues, Sasha Rosenzweig, where we inject 97% ethanol into the myocardium to give us a beautifully reproducible model of cardiogenic shock. And if Mr. Computerman can click the pink picture on the left-hand side, please. So this is us do a left lateral thoracotomy, and we can just titrate the degree of heart failure with multiple 1 mil injections into the myocardium. So and we'll click the top video, please. And this is a normal heart beforehand, and within an hour of we titrate the injections. We'll click the bottom slide, please. And this is it. So this is beautifully reproducible, and we get myonecrosis. I'll not go through this too much, but essentially we can get myonecrosis at post-mortem. You can see exactly what it is. It correlates with everything that you see there, and it's consistent with shock trial data. We do a lot of strain work in the echo field. We get increased LV dimensions. We map using an EP system in our animal lab. We've got our own CARTO system. So we scar the endomyocardium. So really what we're doing now is a randomized control study of pulsatile versus non-pulsatile ECMO in an EF 20% model, looking at this microcirculation, cardiac unloading, and the biological cascade. And Silver's very proud of that cartoon, so I'll just leave that up for 1 second so you can see it. So the primary aim is really to look at the microcirculation via different ways. Won't go through too long, but SDF, NIRS, cerebral microdialysis, and oxygen tension in the brain. In the kidney, renal microdialysis, biomarkers. In the skeletal muscle, oxygen tension tissue, PO2 probes, and NIRS, and also biomarkers. We've got a huge number of different things that we're doing, so it's a very complex study. In secondary outcomes, we're looking at cardiac function, unloading the left ventricle, improved coronary arterial filling, the inflammatory profile that we think is key, pulmonary function, and also the hemodynamics, so macro and microvascular. This takes hours, and all credit to the team, led by Silver and Gianluigi Labasi during the day, but everything is monitored to the nth degree, and then post-mortem we take the organs as well. This is our lab, the animal lab in Brisbane. This is when we're doing transplants between brainstem dead sheep, but we can sometimes do 2 sheep at one time. Again, being Scottish, it saves money. We have, you name it, large, we can actually film into this theatre, so people want to join and not do the 32-hour trip that I did to get here, then they're welcome to have a look and see. And there's just multiple different modalities. There's intracardiac echo, strain, there's C-arms, there's EP mapping systems. The results are not finished, but we will be moving very rapidly to, once we finish this, presenting at ECMONet again, to look at doing a clinical study, looking at pulsatile versus non-pulsatile ECMO, because I think, and there's a QR code if people want to grab a picture, I think the concept of ECMO always confused me. Continuous VA ECMO is opposing a failing heart. It's increasing the LV-EDP. It's reducing coronary filling at certain points. So I think the pulsatility within the VA ECMO may assist from a hemodynamic point of view, but also an inflammatory point of view. With that, I'd like to thank the team and pass back over to Alain.
Thank you, John. We are moving now to Dr. Jennifer Koger from Detroit. Cardiogenic shock definition in the SKYS criteria revisited. Thank you.
Thank you very much. What a phenomenal talk that was. I can apply so much of that both from shock and continuous LVAD support. So that was fabulous. All right, so I've been tasked today with going over the 2022 SKY criteria revised. I have many conflicts of interest, but none that are related to this talk here today. So prior to 2019, a group of very intelligent individuals got together to try to develop a similar equivalent to the New York Heart Association functional class, but for shock patients, to try to put them into categories. And these categories were needed both for assessing an individual shock patient's risk of mortality, but to also help us with future research and to understand how sick patients were going into clinical trials. And this came out in 2019. Patients were categorized based on their presentation of shock as A, at risk, B, beginning, C, classic, D, deteriorating, and E, extremis. And I'm sure most of you in the audience are well aware. And the goal here was for us to speak a similar language, not the same language, but to start to get at speaking a similar language. So as I go through the talk, I just wanted to kind of use 2 patient vignettes just to kind of hone this in. And I think by the end of me presenting these patients, I think most of us in the audience are going to agree that these are classic shock patients, stage C. So the guy over here on the left, he's 75. He's got a chronic heart failure due to an ischemic cardiomyopathy. His EF's 25%. His comorbidities are diabetes and CKD. Comes into our ER and up to our ICU. He was a little confused, very short of breath. He's hypotensive, a bit tachycardic for someone of his age. Satting okay, he's not cold, he's not mottled. He has a bit of a lactate bump, a bit of a creatinine bump. LFT's looking okay, and you get a point of care ultrasound, and not surprisingly, his EF is down. He can generate a pressure of 60. That's pretty stable for him, and his RV's working. A couple hours later, 37-year-old comes in, no past medical history, has been nauseated, vomiting for the last few days, abdominal pain. Look at his EKG. You diagnose him based on EKG and some of his labs with acute myocarditis. He's not hypotensive, but he is very tachycardic. His lactate is 4.4, his creatinine's up, his tropes are up, his LFTs are a bit up, and once you know it, his RV and his LV are down. So both of these patients here, from the information that I've given you, are SKY-C, but they each have different risk factors that are going to modify their mortality risk. So when we look at the SKY categories, we want to look at the accuracy of each of the categories in predicting mortality risk. And this is where me as a statistician comes up with some fancy words. One is discrimination and one is calibration. So let's dumb that down. So discrimination means, do the categories successfully stratify patients into groups of risk? Meaning, Do patients who are in SCAI category D or E have worse outcomes than A, B, and or C? So after the publication of the 2019 consensus document, several subsequent studies were published looking at similar yet different shock patient populations. And what you see here, for the most part, the 2019 SCAI stages were pretty good at discrimination, right? E's did worse than D's, which did worse than C's. Calibration, on the other hand, is the agreement between the SCAI shock group predicted and observed risks. So what that means is if we're going to quote a 70% mortality for a SCAI E, studies largely should show a 70% mortality. And this is kind of where the SCAI categories broke down, because at one point you have a 70% mortality, it's a little lower in this study, it's a lot lower in this study. So the calibration needed a little work. But we got to step back and say the original inventors of the SCAI stages weren't here to prove mortality. They were there to improve the system. And it was up to the rest of the scientific field to continue to improve that. So what we learned from these studies here, and several others that subsequently came out after the 2019 classification, is that there are patient-specific risks that add or modify an estimated risk of mortality. The older you are, the longer you're in shock. Typically, patients that come in with acute MI shock versus chronic heart failure with decompensation to shock do worse. If your RV is involved with your LV, importantly, cardiac arrest. Biochemical abnormalities. Above and beyond a mildly elevated creatinine, a mildly elevated LFT, if you're severely acidotic, you've got a severe lactate elevation, where we're talking if SIRS or vasoplegia is starting to set in, you're a higher risk patient. And then what is your trajectory over the ICU time? So now what do we do? Now what are the recommended strategies for assessing shock? And this is based on the 2022 SCAI stage revision. One, you're going to still categorize your patient into an A, B, C, D, or E category. Remember, these aren't steps. These are gradations of risk. They provided a table providing a little bit more definitive or clearer physical examination findings, typical biochemical markers, typical hemodynamics that you can see. And then we're going to add to that step 2. What are the risk modifiers? Does my patient have other high-risk characteristics? Are they old? Are they frail? Myoetiological features. I kind of made up this word, but essentially, is this acute versus acute on chronic heart failure? Is there electrical instability? Has the patient arrested? Is this biventricular failure? And then hemometabolic factors, lactate, SIRS, ARDS. So back to our patient here, green is usually the lower risk factors, red are the high risk signs. What are this patient's higher and lower factors? He's older. He is a decompensation of a chronic heart failure, but he comes in with more stuff, right? Diabetes, CKD, but his RV looks okay. On the other hand, this stage 2 patient, the good thing going for me is he's young. He's got some reserve. Doesn't really have any past medical problems. His lactate, though, is high. He's compensating. We see that. Young patients, they compensate really, really well. And unfortunately, his RV's down. So the third step of this is reassess, reassess, reassess. And we do this every day, but when we talk about risk prediction, it's exceedingly important. You want to know, is your patient showing signs of recovery, non-recovery, or actually I'll add in here stasis, meaning they're not getting worse, but equally as bad, they're really not getting better. So we learned that from my friend and colleague down here, Dr. Kapoor, looking at the Cardiogenic Shock Working Group, about 3,400 patients. They took their baseline SCAI stage and looked at the frequency of escalation to higher risk stages. So of the B patients at baseline, 90% of them escalated to C, D, or E. C patients, 68% of them escalated over time, and you can see the time to escalation. So, 178 mean hours, that's a lot of time that we have to intervene. So this shows the prognosis. A little complicated, but this is the count in the beginning of B, C, D, or E, and then what they go to. So 23 of these patients stayed B, 25 of them went to C, 145 went to D, and 32 went to E. And then these percentages are the mortality. So while here, B and C had similar baseline, had similar mortality if you judge them by their baseline SCAI class. So B or C at baseline, walking into your ER. But if you followed them over time and you looked at their maximum SCAI category, you see how these two mortalities are going to differentiate out. So to tie this up, what's our summary here? Well, the revised SCAI stages are a recommended framework for mortality risk assessment with risk estimation modified by patient-specific, myoetiological, and biochemical risk factors. Your risk assessment must be continuous, and your care must be continuously responsive to your reassessment. Are they getting better, sicker, staying the same? Our challenge, in addition to continued research, really is to go out into the community. We need to educate EMS, nurses, the ER, the ICU, the OR, the floor rounders, what cardiogenic shock is. And kind of in Michigan, when we go around giving the talks, one of the things I say is trying to educate patients about no and go shock strategy. What does that mean? You teach clinicians to understand what shock is. I know this patient's in shock. I know this patient is not improving with care. And then with that, I know the patient needs to go to an advanced heart failure or advanced shock center. Thank you very much.
Thank you. So we're moving now to Dr. Naveen Kapoor for the algorithm to select devices.
Great. Thanks so much for the invitation to join you today. Great to be here at ELSO and talking about VA ECMO, Impella, or both. What's the algorithm? So when I saw the title, it says algorithm singular, as if there's one algorithm for all patients who require mechanical support. And I think we can all agree that there's probably multiple algorithms. So I'll just break this into about 8 to 9 basic points. As Jen really elegantly pointed out, etiology matters in terms of figuring out what device, what algorithm. Whether cardiogenic shock is due to AMI versus heart failure, two very different pathophysiologies. It's also important to note that in the heart failure subset of shock patients, they're further divided into de novo heart failure or acute on chronic, two very different patient trajectories cared for very different teams. And the de novo patients actually look a lot like AMI patients in terms of their outcomes. They're worse, primarily because the exit strategy isn't as well defined. But physiologically, as Dan pointed out, that schematic shown by Judy Hockman many years ago about AMI patients is also diametrically opposed to what happens with heart failure patients. Heart failure patients tend to present congested, develop hypoperfusion, and end with hypotension because they live in this marinated cocktail of neurohormones. So when we tailor our algorithm, it has to be tailored to the etiology. The next point is that timing matters. So you've heard that several times already from other speakers in this session. Many years ago, when we started to think about mechanical support, it was interesting to hear people use different terms. I need to put this patient on circulatory support. I need to put them on ventricular support. And many people thought they were talking about the same thing. But actually, the hemodynamic support equation we published years ago basically divides into 4 primary objectives of what you're trying to do when you're using mechanical support. The first one is to provide that systemic perfusion, so you can perfuse vital organs. The second is to provide ventricular support, protect the heart from load and essentially unload the ventricle, left or right. Third is to maintain coronary perfusion. And the fourth is to think about renal and hepatic unloading, which 10 years ago was still very early, but now is becoming more front and center. And the challenge here is that at the bottom, that arrow shows that this is all about timing. The longer you stay in cardiogenic shock, it goes from being a hemodynamic problem to a hemometabolic problem. And when it becomes hemometabolic, it's very difficult to now start to pull that patient out of that pit because now you have to do multi-organ support. So this translated, of course, over the years into the SKY stages, which Jen also really nicely laid out. And this was the Cardiogenic Shock Working Group interpretation over the summer that was published, basically looking at bedside parameters such as blood pressure, lactate, ALT, pH, and looking at treatment intensity. How many drugs are you on? How many devices are you on? And did you have out-of-hospital cardiac arrest, which puts you into that E category? And again, this is all about a time continuum. So as we showed, if you present with B, it can be a relatively long slide, but eventually you'll end up in that hemometabolic parameter state. So early intervention is key. Now, when we talk about the devices and you think about the hemodynamic support equation, I think it's really important in the ECMO world to recognize that there's a lot of different ways of thinking about ECMO. And also, ECMO, in my opinion, still remains a very blank whiteboard. There's a lot to understand about what ECMO does to the vasculature, to the myocardium, to multiple organs, and we still have a lot of work to do to understand that biology. But at its most basic level, I think we can all agree, ECMO provides profound systemic perfusion, circulatory support. And as Dan pointed out, the amount of ventricular unloading from ECMO depends very much on your patient's hemodynamic condition and how they're responding to volume status, et cetera. The other thing to keep in mind is when we say ECMO, it's important to recognize which ECMO are we talking about. Are we talking about central ECMO or are we talking about peripheral ECMO? Two very different pathophysiologies. With central ECMO, which gives antegrade flow, the north-south syndrome is non-existent. So always just remember who you're talking to. If it's a surgeon, they may be thinking central ECMO versus an interventionalist or other critical care personnel who usually work in the peripheral domain. And as Dan pointed out, there's a lot to understand about ECMO physiology in terms of ventricular load. So there's the Birkhoff model, which we just saw, and then there's the Dickstein model. And these models are, again, open for interpretation. There's a lot of work to be done here. But we use 3 pre-ECMO predictors of whether or not you're going to develop LV distension with VA ECMO. The first is your pre-ECMO EF. The second is your pre-ECMO MAP. And the third is your pre-ECMO filling pressure, your LV-EDP or wedge pressure. If you have a low EF, low MAP, and high EDP, the likelihood to developing LV distension starts to go up. And I think that also has to factor into what is your central venous volume. With a low RA pressure versus a high RA pressure, a lot of that can be modulated. So that's why there's some confusion in the field about whether ECMO unloads, whether venting is required, and what is the difference between venting and unloading. And that's a separate 7-minute talk, which I won't give just now. Now, what about Impella, which I think it's really great to see that ELSO is really now beginning to think, okay, how do we fit in the space of critical care around cardiogenic shock? Because there are now multiple MCS platforms. And when we think about transvalvular pumps like the Impella, we know that it can provide circulatory support, it can provide ventricular unloading, there's good data about its effect on coronary perfusion, and that's primarily because for the past 2 decades, there's been an intense amount of investigation on this device platform. And I think the same will now come for ECMO over the next 10 years. And one of the things to keep in mind is that HQ curve in the bottom right. So it's important to recognize that device flow through a transvalvular pump is directly related to the RPMs you set in and inversely related to the gradient across the aortic valve. So as that aortic valve gradient starts to narrow when you go from baseline to acute ischemia to cardiogenic shock, then the device flow naturally starts to go up. And in fact, you can augment device flow by giving vasodilators, reducing afterload with these types of pumps. And there's been a lot of work. Some of our work focuses on these preclinical models of myocardial salvage, where we can see in the far right that as you reduce pressure volume area, you reduce myocardial oxygen consumption, and you could potentially achieve myocardial salvage. And this is what has led to the Detroit Shock Initiative, showing that if you can get these pumps in early, unload the heart, maintain systemic perfusion, and you get enhanced coronary perfusion, you might actually get myocardial salvage. And so I think it's important to recognize when we say what is the algorithm, it's important to recognize that one size does not fit all. An algorithm tailored to acute MI shock is required. And usually in these scenarios in our institution, Impella would be first line for SKY B through D. And I'll put in parentheses E because there's shades of gray between D and E. But VA ECMO we consider for patients who have refractory cardiac arrest, for patients with hemometabolic shock. And what we mean by that in our algorithm is as soon as your lactate climbs above 5, now we're beginning to look at VA ECMO first, with an unloading strategy to protect the myocardium and mitigate any sort of myocardial injury related to VA ECMO. And then, of course, hypoxemia, which is, of course, where VA ECMO makes a lot of sense. So this is now being actively investigated, these algorithms for AMI in the STEMI door-to-unload trial, which looks at SCAI A-B patients, and the RECOVER-4 trial, which is now going to be looking at SCAI C, D, and E patients. Now, what about the algorithm for heart failure shock? This is another important tailored algorithm. And as we said, for patients with heart failure shock, we divide them into hemodynamically stable, which means normotensive, elevated lactate, hypoperfusing state, or the hemodynamically unstable patients who have now reached that point of hypotension. For the hypotensive heart failure shock patient, this is where we will start to look again at going directly to an Impella 5.5, for example, because usually in those dilated ventricles, a CP pump may not be sufficient with 3.5 to 4 liters per minute of flow. But generally, again, the same consideration for VA ECMO. If they're elevated lactate, hemometabolic shock, worsening end organ perfusion, the combination of the two technologies are not in conflict, but actually in confluence with each other. So this is also going to be investigated in the upcoming ECLS shock trial, which we'll hear about hopefully in March, April around ACC. Again, looking at VA ECMO and AMI, but still a wide open space for VA ECMO and heart failure shock. The pragmatic arrest trial, I think you're all familiar with, so I won't belabor this point, but prove that, again, in out-of-hospital cardiac arrest, VA ECMO is likely superior to ACLS, especially with resuscitatable rhythms. Now, there is emerging data suggesting a benefit of ECMO combined with Impella. This was just published by Will Grandin in our group, looking at the ELSO database, suggesting that ECMO with venting leads to lower mortality despite higher bleeding, higher risk of hemolysis. And so I think this is an interesting area of development. When you look at the hemodynamics, when we put patients on ECMO, you can see baseline PA pressures around 50, RA pressure sitting around 10 to 15. As soon as we activate ECMO, within minutes, there's an increase in the mean arterial pressure in red and purple. But what you can see is the PA pressure has come down, the RA pressure is down in blue and yellow. And 15 minutes later, this patient now has low filling pressures and has a good stable mean arterial pressure. And the question is, do you need to vent or unload this patient? And so that's where I think the distinction comes into play. In the same patient, we put in conductance catheters, and we show that going from baseline to 15 minutes on ECMO, the pressure volume area is not changed. So this patient doesn't require venting to reduce LV-EDP, but also is not unloaded at the same time, and that would be a reduction in PVA. So does ECMO plus Impella solve the hemodynamic support equation? I think it does, actually, rather effectively. The problem is that as you start to add more MCS, the complication risk starts to escalate. So we've got to learn more about ECMO in terms of how to optimize those loading conditions with that platform, and Impella is one option to consider. And this also will be coming out from the same, we responded to a letter, so Will Grandin put this together as a framework for an algorithm, this is the third algorithm, for when to use LV mechanical unloading with VA ECMO. And this will be in the slide deck for folks to look at. So the take-home messages are that when you're thinking about an algorithm, think about the etiology, think about the duration of shock, the severity of shock matters, understand your technology, what are the different objectives you have for your technology, and tailor your algorithm to the subset of patients you're dealing with. And again, that physiologic, biologic impact of VA ECMO remains largely unexplored, so we're excited to partner with ELSO to examine this further. Thanks very much.
So Dr. Salazar could not make it to the meeting today, so I rounded a few slides during my trip here to Boston to talk to you about biventricular dysfunction in the setting of cardiogenic shock. First, these are my disclosure slide. So a lot has been already said about cardiogenic shock and specifically about the causes that leads to severe cardiogenic shock. We can classify those etiologies in three great categories. Medical cardiogenic shock, it's mostly patients who have acute MI and end-stage dilated cardiomyopathy, might also be myocarditis, septic shock. Takotsubo drug overdose. The second category is those patients who have post-cardiotomy refractory cardiogenic shock, might be so-called rigorous cardiac surgery or heart transplant, LVAD surgeries, and those patients who have cardiac arrest. And depending on the etiology of these shocks, these patients might have preferentially isolated left ventricle dysfunction or biventricular dysfunction. And it's mostly patients with acute MI who might have isolated LV dysfunction. So some now epidemiologic consideration here. This is a study conducted in France on administrative database showing that in terms of frequency, the most frequent one were patients who had decompensated heart failure. Second etiology was cardiac arrest, and in that series, in ICU patients, acute MI was the third one with 17%. It might be a little bit different when the cardiac ICUs are concerned. This is another large database from the Cardiogenic Shock Working Group registry showing that heart failure is still the most frequent etiology of cardiogenic shock, acute MI being the second one, when 1/3 of the etiologies. And as already mentioned, those patients who have acute MI have a higher mortality overall than those patients who have heart failure. So second step now is how to diagnose, especially for those patients who have acute MI. You might rely on the SWAN with the classical indices here suggesting RV dysfunction or severe RV dysfunction, or you might also rely on echocardiography. Those are here data from the shock trial and registry showing that in up to 1/3 of the patients with acute MI, there might be actually either biventricular failure or predominant RV failure. And I will skip this slide for the sake of time, showing the step-by-step examination of the patients with heart failure to diagnose RV dysfunction. This is actually very important because you may miss some RV dysfunction if you rely only on the SWAN. And I like this algorithm showing that you can, with this 3-axis model of cardiogenic shock, better define and stratify the evaluation and the prognostication of patients with cardiogenic shock. And within these risk modifiers, of course, as already been shown before, RV versus LV and biventricular dysfunction is a strong modifier regarding the prognosis of these patients. So which category of pump, MCS, may be used in patients with biventricular dysfunction? There's some devices I will discuss in the following slides. One important message here, the big machines, the big valves, the HeartNest 3 or the total artificial heart are clearly not for those patients who have acute cardiogenic shock. Those are big machines, very costly machines. They need specific heart surgeries. So clearly we need to focus on short-term devices for those patients with the most severe forms of shock. A few words about the tandem hearts, which drains the left atrium through a transeptal cannula. This is a pump which is not that frequently used. There's high risk here also at the transeptal cannulation with risks of cardiac puncture and tamponade here. And the residual atrial septal defect is also a limitation of that technology. So we are mostly talking about the impella, as nicely demonstrated by Dr. Kapoor in the previous talk. The left-sided impella are obviously only for left ventricle support. But there is another impella, which is the RP, which might be also combined with another type of impella pump, either the CP or the bigger 5.5. And there are some papers showing that this bipillar strategy might be applied to patients with severe biventricular dysfunction, like in that paper here in a mixed population of patients with acute MI and also advanced heart failure, with a good survival rate, which actually was 50% in that series of patients. But we also have a lot of big question marks about the use of the impella. And this is one of the latest, published just a couple weeks ago on an administrative database as well, showing that altogether there's many limitations, of course, to these retrospective registry data, showing that there may be a higher mortality with these pumps, even as compared to the balloon pump. As we know from the IABP shock trial, that this balloon pump does not improve mortality as compared to regular medical treatment. So clearly we need more here about the impella and specifically the combination of these different types of pump in the setting of cardiogenic shock. Then we have VA ECMO, which may be used also first line in patients with cardiogenic shock, whether it is limited to the left ventricle, but also to those patients who have biventricular failure. The latest algorithm clearly advocate for the use of the impella for SCI-E patients. But should we move from these SCI-E patients for whom we know that ECMO can save lives? This series we did in France showing that for those patients almost dying of refractory cardiogenic shock, 50% of them might be rescued by this strategy, and with a good chance also of a successful winning without the need for a big VAD or heart transplant. But beyond this population of super sick patients, those who have reached the SCI-E classification, is there room for less sick patients, class C, D, and E? And we may learn a lot from the ongoing trial. There is the ECLS shock ongoing in Germany, for which Olga Thiele is the primary investigator. They have randomized more than 300 patients now, and we might have the results of that trial in the coming months. And we are conducting in France also the anchor trial in the same population of patients, with the objective to include patients with SCI-C, D, and E, which mostly SCI-C patients with the indication of ECMO in that trial with the combination of the balloon pump. And actually, VA ECMO, as already mentioned, as a major limitation is that it increases LV afterload by the countercurrent reinjection of the blood within the aorta. And with the high risks of pulmonary edema and also the higher risk of mortality. And we have some strategies which have been used to improve the outcome of these patients by the so-called venting of the left ventricle, might be the balloon pump, might be the impella, might be also to do a natural septostomy with a balloon to drain the left side to the right side. And we also have convincing data from the ELSO registry, a paper published a couple months ago on a large series of patients who got VA ECMO for cardiogenic shock and who get LV unloading, whether it was the balloon pump or the impella which was used, and clearly showed that the in-hospital mortality was less for those patients who got unloading. And there was also a trend towards less mortality with the IBP. We need more. We need now to investigate what is the best strategy. Is there the need for an escalation? Do we need to insert some kind of combination strategy on top of ECMO in every patient, or do we need to select a specific group of patients to also vent the left ventricle? And beyond FEMFEM via ECMO, we have other strategies. This is another strategy we use from time to time in my department, is central ECMO, but with 2 ECMO devices. We use ECMO machines as a BiVAD, actually, in those patients, draining the right side from the right atrium to the pulmonary artery, on the left side from the apex of the LV to the aorta. we use this strategy usually when the patient has been on VA, FEM VA, Propofol VA for a couple, let's say, weeks and does not recover, is not yet a candidate for heart transplantation. And we use this strategy to select those candidates we might qualify for transplantation. This is a strategy we have applied to decompensated heart failure patients, and this is on the left panel here. Some of these VA ECMO were switched to the central bilateral ECMO strategies, and half of them were actually transplanted. Similar data here from the group of New York, and this group also published less invasive strategies using cannulation of the apex and reinjection into the axillary artery to help the left ventricle. And on top of that now, you may use also the ProtectDuo to provide percutaneous right ventricle support. So we have a lot to learn in the coming years about what might be the best strategy for those people who have bad ventricle failure, and also to define the strategy for those patients who are deteriorating on VA. And this is my last slide, an invitation to our Congress in Lisbon next April, and also for the Red Book. Thank you so much. And now I have the pleasure to welcome on the podium Susanna Price for the future.
So thanks very much. And I've been asked to look forward to the future of where we're going to be going with cardiogenic shock. It's going to be a short talk, and I'm going to take you on a slightly different place from where we've been for the rest of the session. I've got no disclosures related to this or indeed any other presentation. So I'm a cardiologist and intensivist. We're talking about the heart, and in order to understand where we're going to go in the future, we have to look back a little bit and see where cardiology has come from. So these are some of the key points in cardiology, how things change. So 1929, the first heart catheterization was undertaken by Forsman, who was sacked from his job after he did that. 1941, Cornand and Richards measured the cardiac output, and the next year, these guys, Forsman, Cornand, and Richards, shared the Nobel Prize. Soanes undertook the first accidental coronary angiogram back in 1958, and Dotter did the first angioplasty, which was peripheral, in the 1960s. So now we're going to turn to the 1970s. The 1970s were extraordinary times. So first desktop computer, formation of this company. Concorde flew for the first time. This man died. Saturday Night Fever was released. The Star Wars films were started. Diphtheria was first recognized. Smallpox was eliminated. And for Alain, the last person criminal in France was executed with the guillotine. So that was the 1970s. Now, in the 1970s in cardiology, something else happened. This guy, Andreas Grundsig, he was extraordinary. He presented at the AHA. He'd undertaken angioplasty, coronary angioplasty in man, and he was ridiculed in 1976. 1977, he went back and presented further angioplasties in men. He had a standing ovation, and Soanes, the guy who did the original accidental angioplasty, was moved to tears. So things really changed in the 1970s, and some would say 77 was the year that changed cardiology completely. So what happened since then? Things did carry on. So I had the pleasure and privilege of working with Ulrich Sigvart. Ulrich Sigvart is an extraordinary gentleman. He invented the self-expanding stent, and by that, PCI became safe and predictable. And it's now the commonest medical procedure that's undertaken globally. If you look at cardiology now, everything is catheter-based. You go and have your new valves, you can have your valves repaired, you can have them replaced, you can have your ablation. Everything goes back to what that extraordinary man, Andreas Grundsig, did in the 70s. So meanwhile, in the 70s, We heard earlier today from Bob Bartlett about the first case of ECMO. And although there have been small steps forward, there has been nothing quite like the revolution that there has been in cardiology. And some of the cardiologists regard critical care as a bit of a kind of tumbleweed moment, that nothing really has changed. And we see that with our mortality in cardiogenic shock. It's not really fallen. So if I look to the future, really, from where we are now, what am I going to talk to you about in the next 2 or 3 minutes? A little bit of a rethink about what we're doing with cardiogenic shock. Is there somewhere else that we can learn things from? What about predicting decline? What about artificial intelligence? What about the concept of the heart as the innocent bystander in all of this? Maybe it's just a biomarker that shouts very, very loudly indeed. ECG changes, chest pain, cardiac arrest. So it's a biomarker for a much broader disease. And then something about future technologies. So cardiovascular disease is the biggest killer. One of the other biggest killers is cancer. And if you turn your eyes to what our cancer colleagues are doing, they are in a totally different place. So now they genetically test you and your tumor. So they begin to understand who you are and what your tumor is. They're using targeted immunotherapy, so they use your immune system to seek and destroy the cancer cells. And in patients with metastatic disease, they're now looking at real-time bespoke radiotherapy with beamlets that will actually seek and destroy cancer cells where they haven't yet been recognized by conventional testing. So the concept of theranostics. And they're thinking about different ways of delivering chemotherapy in ways that they'd never thought of before. So our cancer colleagues are phenotyping and genotyping their patients and the disease much more than us. As intensivists, we're treating these patients probably way, way, way too late. We're doing the equivalent of running a whole surgical metastatic program. You've already got multi-organ failure by the time we recognize it. So we need to be able to work out when the patients are going off-piste much, much earlier, those who don't need the devices that we've got, or those that are going to need interventions way over and above. So we need to look beyond the heart, and we need to understand the genomics, proteomics, and metabolomics of our patients. And the cardiologists are beginning to do this. This was a session I went to at the European Society of Cardiology, looking at metabolomics and targeting them post-out of hospital arrest. So not only what the patient has and what they are, but their response to critical illness. Then there is predicting decline. So I've put this up. This is the holy grail of where we need to know which patients aren't getting better. And what we have at the moment is the most appallingly suboptimal instrument for predicting decline. It would be like trying to prevent a car accident by having a detector for smoke and flames. The accident has already happened. You need to work out way before the biomarkers start going up what's going on with the patient. There's a lot of talk about big data. What about correlations? And people are very anxious about these. And this is a great website where you can look for useful correlations. So this is a correlation of the number of people who drowned by falling into a pool with films that Nicolas Cage appeared in. And you see a beautiful correlation here. And I've got another one, per capita cheese consumption with the number of people who died by becoming entangled in their bedsheet. So you have to be very careful when you're looking at these data. Nonetheless, if you use big data and artificial intelligence well, it can be extraordinarily powerful. And what I can envisage in the future is that machine learning, the machines will be able to learn when your patient is going off-piste and what you need to do about it. So the machines will be our friends for our patients. What about molecular imaging? So we've talked about inflammation. This is from Peter Libby, way back 20 years ago now, saying vascular disease is an inflammatory disease. We've heard about inflammation and the endothelium and vascular disease in patients with shock. Well, what about molecular imaging, and are there potential targets there? Well, yes, we can look at vascular inflammation, looking at supramagnetic nanoparticles, and we can demonstrate where this inflammation is. And now you're going to walk with me to one of the coolest experiments that anybody, I think, has ever done. So we're going to talk about nanobots. So nanobots are biocompatible machines on or at a near nano scale. These guys got the Nobel Prize in 2016 for it. And the potential, therefore, is to be able to use these nanoparticles to be able to deliver drugs. And these guys did an extraordinary experiment. So what they did was they made some nanobots. So it's basically origami DNA. And they have these doors of iron oxide nanoparticles. And then within the origami DNA, they put a fluorescein dye. Okay, then they close those little doors. And the drug sits in this origami DNA, and you can open and close the doors and expose the patient or the cockroach to more or less of the drug, or in this case, a fluorescent particle. What they did, which is even cooler, was they put EEG hat on the patients and on people, and they put the cockroach in a little electromagnetic coil. And they let them read a book, and it was connected. The computer was reading their EEG, was set up to detect when there was a change in cerebral activation. Then they made them do some long division. It changed the activation of around the ferromagnetic coil, and the cockroach fluoresced. So think about that. You, by the power of your mind, can control what happens in drug release in another living being. Extraordinary. So the potential to do this on a vascular level is absolutely there. Then if you think of stuff that's already in development, well, flexible sensor technology, the wearables, the innables, the outables. What about the heart on a chip? You can look at all of your organometrics that you can do with that. Cell therapy, so virus vectors as pacemakers, quite extraordinary innovations. 3D printing. If you want us to 3D print you a little tiny extracorporeal support device, we can do that. How about having them in your limbs that you can dial up and dial down the amount of support that you want? Completely change things. And then finally, what about digital trials? What about your digital twin that they can test everything on before you actually have to be subject to the intervention yourself? So that's kind of my little walk into the future. And you might think that I'm completely mad, but let me walk you back to 1936. So this is a fantastic movie. It's a movie everybody knows about, Boris Karloff. It's actually a gangster movie, but remember, this is nearly 100 years ago. And in this movie, basically, a guy gets accused and convicted of doing something he didn't do. It's a real proper gangster movie. He dies, and the mad scientist decides to bring him back to life. This is the Lindbergh artificial heart, talked about nearly 100 years ago. Here is Boris Karloff. And so they predicted in 1936 the use of extracorporeal support, the use of an artificial heart, and they even predicted, if you look at him, he has a hemiparesis, the complication of stroke. So I may be mad, but I think probably the future's now. Thanks very much.
So thank you so much for attending. It was a very nice session, and I invite you now to go to the third floor for the gathering. Thank you.